Good afternoon. I am going to try to take you through some of the clinically applicable observations on MRI. I need to tell you that I'm here replacing my son, who is the actual investigator responsible for most of these data. Couldn't be here, although he wanted to be. The timeline for this, meaning imaging in hypertrophic cardiomyopathy, has gone through these phases from M-mode echo, which is now and echocardiography, very old. There really wasn't much after the Doppler was invented to the time where we have really enhanced our ability to look at this disease, a disease which is very applicable to non-invasive imaging, obviously, as many people have already said. The advantages for MRI, tomographic high resolution, allowing cuts through the entire ventricle, not missing anything, and the ability to put that all back together again is really the basis for the observations that I'm going to show you. They are pretty pictures, and in hypertrophic cardiomyopathy we can see the distribution of hypertrophy and make more precise measurements than was ever possible with echocardiography, reliable and reproducible. But it's not really just an issue of pretty pictures, and that's where I'm coming from today. One of the first things we noticed was that we'd always thought that this 12 o'clock area right here, that would be at the top if we had the echo display, that this was the thickest area of the ventricle in hypertrophic cardiomyopathy usually, but actually it seems to be displaced a little bit toward what we call 1 o'clock, toward the RV insertion. That's where it's really thickest. So all these years we were looking at what we thought was the thickest at 12 o'clock is really somewhat thicker in the patient population, removed, and in an area that the echocardiogram didn't really provide precise measurements very often. And with that in mind, the diagnosis of hypertrophic cardiomyopathy has been enhanced by imaging for at least some patients. This is an example of a family member with the disease, a completely normal two-dimensional echocardiogram, and it turns out that there's this segment of the left ventricular wall and the anterior lateral free wall, which itself is thickened and makes the diagnosis. So this patient becomes phenotypically positive, becomes a patient with the disease, has a family history of sudden death, and is implanted with an ICD because of a risk factor, which turns out to be a good idea because there was an appropriate discharge later. Diagnosis only possible with MRI. And that takes us to this question of the MRI providing more information for risk stratification. I'm going to be talking about late gadolinium enhancement later at the end, so don't go away. But I know that's of great interest to everybody, of course. But there are other issues related to risk. Here's an example, and of course massive hypertrophy is a risk factor. The the echocardiogram over here shows hypertrophy. It's diagnostic. There's no question this is a patient with HCM who has some hypertrophy spilling over into the anterior lateral free wall. You apply the CMR, and all of a sudden, it turns out that there is substantial, if not massive, hypertrophy in this area. Now, how did that happen? Well, you know, for years, we have always assumed that this margin here was an interface. It sort of looks like it should be where we have indicated it, but it's not. It's the epicardial margin, it's not the endocardial margin, which is much more discrete. And it turns out that there's a bulge there that would not have been imagined just with two-dimensional echo. So this then becomes a patient with a risk factor as the previous patient because it's massive hypertrophy, and that was a good thing because a device was implanted, and that also produced an appropriate intervention eventually. So you can see two examples, two different risk factors, and all of a sudden MRI in this very diverse population is providing clinically relevant information. It's not just pretty pictures. The other area is the apex. This is an example we borrowed from the UK, but you know, you've all, I'm sure, had this experience where the apex is foreshortened by echocardiography, and then you go over here with the MRI and you have the spade deformity and the apical version of HCM. So it could be diagnostic there, but it can also have an application in the apex for risk and management because we've found these apical aneurysms are usually identifiable only, or best certainly, with CMR. Here's a whole group of these aneurysms. I'm sure you're familiar with them. They come in different sizes and shapes. Sometimes they can have a clot in there. And this is perhaps the last subgroup in hypertrophic cardiomyopathy, previously unrecognized largely because you needed the CMR to image the apex to produce these pretty pictures, which are very clinically relevant because it turns out with the gadolinium, of course, the rim of the aneurysm, which is very thin, it could be 1 to 3 millimeters, is scarred, but also the areas adjacent. It's apical scarring with the aneurysm. That's the lesion, apical scarring, and it is relevant to risk. Cardiovascular event rate, at least in the first group of patients that were identified, in Minneapolis and Tufts, over 10%. So again, very relevant observations. You know, this is a disease of the left ventricle, but again, CMR provides the opportunity to look at the right ventricle for the first time. And many of these patients turn out to have a spillover effect of hypertrophy into the right side. The significance of this is not known. There is no data yet that would implicate this morphologic pattern as worse than any other or distinctive in any way. But again, it is demonstrating the anatomy of the left ventricle that we weren't able to know about when confined to echocardiography. And this also includes structures that are not the left ventricle. The mitral valve is part of the primary disease state. So this is a disease of the sarcomere, but that doesn't mean that there are not non-sarcomere components that are part of hypertrophic cardiomyopathy. There could be greatly elongated anterior, posterior leaflet. There are a wide variety of patterns of mitral valvular elongation, and this is part of the mechanism for left ventricular outflow tract obstruction. And these leaflets can be quite long, and you can see that we're in this range for leaflet length based on the MRI. This also becomes a way of aiding in diagnosis, particularly in patients that have borderline findings, like marginal wall thicknesses and also family members. If you have anterior leaflet length, for example, that is 28 and 30 and above, this is perhaps a clue to, in the absence of genetic testing at least, for the diagnosis of hypertrophic cardiomyopathy. The mechanism of left ventricular outflow tract obstruction, which is muscular and doesn't have anything to do with SAM, the anomalous insertion of the anterior lateral papillary muscle into the mitral leaflet, which is very important. Mechanism, although uncommon, because its recognition is crucial to the operating surgeon. And its presence pretty much should contraindicate alcohol septal to relieve obstruction. So it's another image. You can see that the anterolateral papillary muscle inserts directly into the anterior leaflet of the mitral valve in the absence of chordae tendineae. Another image that has clinical relevance. I'm sure many of you have seen these little clefts, okay? They're blood-filled, narrow crypts within the myocardium, can be in the septum or the free wall. And they have, as it turns out, some diagnostic relevance. Because while the crypts can occasionally be seen in the fully formed phenotype of hypertrophic cardiomyopathy, they're very common in family members who do not have left ventricular hypertrophy. So we know that's the case. We have a separate group of patients that are genotype positive, a phenotype negative, and the crypts are very common. That would mean that in the absence of genetic testing, the crypt formation that I showed you here could be a clue to the diagnosis of an affected individual with hypertrophic cardiomyopathy in a family when perhaps genetic testing will not provide the answer, which is not uncommon. You know, there's probably going to be a lot of relevance to measuring left ventricular mass. This is something that CMR can do that echocardiography cannot do in hypertrophic cardiomyopathy. It turns out this is Jacopo Lovoto's work, and it was interesting that there was a substantial minority of patients, about 20%, who, with hypertrophic cardiomyopathy, who had normal, calculated, indexed left ventricular mass. How is that possible? This is supposed to be a disease of left ventricular hypertrophy, and they have normal, calculated mass, and that is a reflection of segmental hypertrophy. Mild, relatively mild segmental hypertrophy confined usually to one small segment of the left ventricular wall. So it is important to know that an increase in left ventricular mass in the MRI lab is not obligatory to the diagnosis of HCM. It's still a matter of wall thickness. So coming back to this question about risk, and many speakers have already talked about this with good reason, because presumably gadolinium is telling us about replacement scarring, interstitial fibrosis. We're not sure. Whether all LGE is scar is not known. But anyway, in hypertrophic cardiomyopathy, and this is Paulo Spirito's work, we have a subset of patients who are at risk but don't look like it. It is the low-risk group that do not have any of the conventional risk markers. Yet events occur. So this is the other side of the coin to risk stratification. Patients who cannot be identified by the standard risk markers and therefore would not be candidates for primary prevention ICDs. Oh, it's natural to think about the LGE in this regard. And there's data out there that says that the presence of LGE, called DE here, for example, these are data from an ambulatory Holters. These arrhythmias, like NSVT and couplets and PVCs, these ventricular tachyarrhythmias, are much more common on the Holter in patients who have some LGE. So it suggests that the LGE, whatever it is a marker or a nidus for generating ventricular tachyarrhythmias. Don't forget, we're talking about the presence of LGE in these studies. Not how much, just that it's there. And that's really a crucial issue in using this modality because LGE is very common. Study that I'm going to show you is a little bit less than 50%, but most studies out there will put it at, depending on how the thresholding was done, will put it at 50% or more, up to, I've seen 70, I think even 80%. You can generate LGE technologically, of course. Either way, it's too common for the presence of that finding to, in and of itself, become a risk marker. I mean, how can you implant more than half the patients because of a little bit of LGE? It doesn't make sense clinically. But there are studies out there sort of suggesting that or allowing that to be the inference. Now, we had an experience a few years ago with a patient that made us think that there was another way to look at it rather than the presence of LGE. This was a young college student who had a routine CMR, because we do it routinely. And previously, no risk factors, very innocent, not very thick, and all of that. And all of a sudden, this very bright, high signal intensity LGE was evident. It was difficult to ignore, but there was really no significance that could be attached to it based on any data. But it was a lot of it. It was about 20% of the septum, estimated at least. His mother is a physician, and there was a discussion, and eventually a device was implanted, and then you can see that it only took about 9 months for it to terminate spontaneously ventricular fibrillation. So dramatic experience like that made us think that we really needed some evidence relative to the extent, not the presence, the extent of LGE. It's the only thing that seemed to make sense. And we have these data. The data I'm showing you now are not published. It's under review, but not published. And it is unique because we're talking about almost 1,300 patients at 7 major HCM centers that combined to create this database. All patients obviously with CMR, and then a follow-up afterward, relatively low event rate, and then the two principal findings were that the extent of LGE, as I suggested, the extent independently predicted risk for sudden cardiac death. Whether there were risk factors present, or perhaps more importantly, if risk factors were absent. In other words, patients who didn't seem to be at risk conventionally. And the second finding, perhaps not as dramatic, was that the extent of LGE independently predicted patients going into this end stage we've been talking about with systolic dysfunction, predicted the future occurrence of that as well. So these are the data on LGE in this patient population related to sudden death with or without risk factors. And turns out, as I'll show you, that if you cut this at 20% or more, then you probably have the cut point that is most relevant for interpreting this amount of LGE as significant for the generation of arrhythmias and sudden cardiac death, as well as it turns out, the end stage. It's interesting that in this disease, a lot of LGE can either go to the sudden death pathway or alternatively to systolic dysfunction. So if it's fibrosis, it's acting in two ways in the patient population. Perhaps it's better to look at the data this way, by relative risk. And this chart includes only patients who were without conventional risk factors. So this is the group that's novel. This is the group that needed to be identified because they would then become candidates for ICDs and primary prevention of sudden cardiac death. And in relative terms, that 20% cut point that I suggested to you before is about 2.5 greater risk than a patient who did not have any LGE. That's the way these data are priced. So if you have two patients in the clinic, one without risk factors and no LGE, and the other one no risk factors with 20%, then that second patient has a relative risk of 2.5 to the other one. That's one of the ways you could look at these data and try to put it into a clinical arena. Doesn't mean that 15% doesn't, it means also that 15% has a significant 2 to 1 risk to 0 LGE. So these are the numbers that can be used in interacting with patients who do not have risk factors, but have what we're suggesting here, a novel new risk factor based on the CMR with contrast, the extent and the substantial extent of LGE. So that's, I think, something new. Just as a sidelight, all of this, I think, started at Northwestern mostly with identifying these areas of LGE at the insertion points where the septum meets either the right or left ventricle, which turns out to be an area of disorganized cellular architecture, and fibrosis, and everything. And we don't think that these areas mean the same thing as what I just showed you in terms of the data, because we have virtually no events in patients with isolated insertion point LGE. So that can be a source of some confusion. And I think also these data really are helpful on the other side of the coin, because the absence of LGE, it does not immunize patients from the risk of sudden death. There are many mechanisms, and we're not completing the story here. But certainly for the patient population, the absence of LGE has to be considered a favorable feature. So, sort of in conclusion, the guidelines have been shown, the recent guidelines from the ACC and American Heart about who gets the CMR, okay? And it's complicated. In fact, if you read this and tried to abide by it, to try to figure out who gets this test, it'd be hard to do. And I say that knowing that I participated in the formulation of this, because I think it can be simplified. I think that really all patients with HCM have to have magnetic resonance imaging. It's a routine part of the evaluation. You cannot pick and choose because you don't know what you're going to find. It's no more complicated than that. And we've already shown a vast array of potential findings that really only CMR can provide, or at least reliably relative to echocardiography, finding areas of hypertrophy and making the diagnosis that couldn't be made otherwise, as I showed you. The elongation of the mitral valve leaflets can have a lot to do with planning surgery. Sometimes surgeons want to plicate those valves in addition to resecting muscle from the septum. Findings like the crypts can be very helpful in identifying affected family members in the absence of genetic testing, differential diagnosis, and then most importantly, I think, this issue of prognosis. I mean, how do you not, based on these data that I just showed you, how do you not have a CMR for every patient? Because it would have to include those patients that don't have any risk factors, and they may be at risk, but you would only know by contrast CMR. The apical aneurysms, the thrombi, papillary muscle structure for the surgeons, all of these things are really essential to the best evaluation of this complex and heterogeneous disease. Thank you very much.
We published 2 weeks ago a study on Journal American College of Cardiology where we repeated 2 magnetic resonance study in patients with HCM after a follow-up of 2 years. At the first magnetic resonance, we found a prevalence of late enhancement of approximately 80% of patients. This is a study with Italian patients. And after 2 years, the prevalence passed to 96%. Almost all of them, so this patient have the late enhancement of the second magnetic resonance examination, and in the patient with late enhancement of the first study, all of this patient had an increase of the extent of the GE, rating from 0.5 to 1.6 gram for months of increase of late enhancement. So after only 2 years, on average 2 years, most of these patients increases the extent, some passing from 1% of mass to 10% of mass, other to 10 to 20% of the mass. So can you comment on this? We have to repeat magnetic resonance at the time in patient with no existing criteria, risk factors, and without ICD, without indication for ICD.
Right, we do that. Every visit, which is usually on an annual basis, includes MRI. So I agree with you. What you're saying supports what I'm saying, right?
Thank you.
Bob.
Barry, thanks for a great presentation. And could I bring you back to this discussion you had about the crypts? I think you said it well. We're all seeing those, and we're not sure exactly what to do with them. And it kind of crosses the boundary sometimes between what one would call non-compaction, versus crypts in some cases. But what do you do when you have crypts like that in a patient, in a family member who has no hypertrophy and otherwise phenotypically normal? Does that person now cross over to HCM based upon the crypts alone?
Well, first of all, the crypts are in the base, and the non-compactions are the apex. So they're really very different. And yeah, I mean, I guess you could also say it makes successful genotyping more important. If somebody has a crypt, to definitively document that they're affected, then, if genetic testing will work for that patient. But I think that basically those examples that I happen to put together here in family members, that strongly suggests.
I guess my question is an 18-year-old athlete. What would you do with the crypts?
I see. Okay. Well, in the United States, you can have you can be phenotype negative and allowed to play. You can be gene positive, phenotype negative. Bethesda Conference 36 does not disqualify you, so it probably wouldn't affect that. Might affect it here, though. Yeah. Yep. Oh.
Please wait for the microphone.
I would like to add something to the discussion of the crypts, because we performed a study in Amsterdam, scanning every patient having a special crypt shot, and we saw that in the normal population, we had a very high prevalence of 1 or 2 crypts in non-HOCM or HOCM-related groups. And when you find 3 or more crypts in a group in family members of HOCM patients, that was most discriminative for eventually developing HCM. And we see also in studies we're following these groups that the ones who have the crypts seem to have a little bit more progression to HOCM than the ones who are genotype positive but don't have any crypts, or 1 or 2 small ones.
Yeah, I don't think you can apply this crypt thing to the general population suspected of having heart disease. I think in families it becomes, important.